Okay, welcome everyone to ICCPR's International Cardiac Rehab Registry's second quality improvement session. I'm Professor Sherry Grace and the co-chair of the registry, and I'd like to welcome all of you here today. Okay, so first of all, let's talk about and introduce the most important people who are the members who are participating. So the programs in the registry. So I see in the chat, or sorry, in the participant list that we have quite a few centers here. So if anybody wants to come off and say hello or write a note in the chat about where you're from, so we can put a name with the locations here, that would be lovely. But I see that we do have folks here from the Qatar site, from the India sites, and Colombia, and Mexico as well. So welcome to you. So I'm Sherry Grace, as I mentioned, and I'm the co-chair. I'm in Toronto, Canada, and I'm a professor in the Faculty of Health at a university and also involved in a rehab program in Toronto. And I'm hosting this on behalf of the ICRR user subcommittee, which is chaired by Dr. Gabriella Gysi, whom I will introduce in a little bit, as well as the co-chair, Dr. Dion Candelaria, who is leading the quality program quality piece. And I'd also like to thank Dr. Fabia Raida, who is our ICRR secretary and who helped us organize this, but also will be working on this as part of her thesis work to help us really augment and extend our ability to support the programs participating in the registry in their quality improvement activities. So I've been involved with the ICCPR since it was founded and serve on the executive as well as a research advisor. So just to orient everyone again and remind them about the registry quality initiatives. So we do aim to support programs to use their data to understand their program quality and track it, but also to then, if they're interested and if they have the capacity, to improve quality in some areas where they feel they have the resources. So early 2023, earlier this year, we had our first session and we talked about engaging women in rehab and how we could increase that. The webinar is available on the website with the information. And then subsequent to that, we had some in-camera discussions amongst the programs about the challenges and experiences working to increase women's engagement at their programs. Today, we are doing our second topic. Again, this was also chosen based on a look at the registry data and kind of getting a sense of where we're at. The quality overall is very, very good, but everywhere around the world, given our low resources, there are areas where we can improve. And so today we're going to talk about patient barriers to rehab, session attendance and adherence to programs, and even probably barriers to even offering more sessions to patients in low resource settings. Based on the data, we'd also like to, we propose to next year have a session on patient information needs and knowledge and share some of our information around that on a global basis. And we have some resources as well around education through Dr. Gysi. So again, we have some tools to support quality improvement in that area. And we hope to organize that session. So next year, stay tuned. And we would love to hear from you, of course, about future topics. Based on the data, we are considering one around mental health. But again, we're happy to hear from you. And we always record these so that they are available for future viewing by future sites that participate as well. So about today's session in particular, So I'm going to start by speaking about why we need to address this, and about why we need to address this issue. And then we'll talk about the performance of the registry sites. And we have some congratulations to give to several of the centers that have been kind of the top performers. And then I will introduce Dr. Gabriella Gysi, who will talk about the top barriers that patients express in different regions of the world. And then I'm just going to briefly touch on the barrier mitigation strategies that we would like to suggest. Obviously, you need to tailor to your context, but we'll get you started with some suggestions that we have. And then I'm going to pass it to one of our programs, who, as I mentioned, is one of the leaders in performing in these areas. So Dr. Claudia Enrique Santos of Colombia will share some of her site best practices with you. And then at the end, Dr. Dion will do kind of a Q&A and a wrap up with us. And yeah, so that's the plan. So to get started with me, so this is a review that we have, I guess the kind of the question of, how many sessions should patients get to start with? And I think all of us here know that more sessions are better. And we can get them as much as we can, but feasibly, it costs money to provide the sessions, and it's difficult for patients to go. So really, what should be the minimum amount that we're aiming for, where patients have barriers. So we did a review a couple of years ago now of studies where they reported the number of sessions that a patient got, and these are supervised sessions, about an hour on average of exercise and a bit of education, where they had different outcomes like mortality or revascularization. And so you can see the publication here if you're interested in looking at kind of other outcomes. But I wanted to summarize here, just showing, that really the idea that more is better. So we ended up grouping the number of sessions as kind of low with less than 12 sessions offered, medium dose being around 12 to 35 sessions, and then high dose or sessions around 36 plus. And it really did a lot of the studies did kind of hang around this, because in the States, there's this 36 session standard. And so a lot of research has been published with that number of sessions. And then in a lot of other jurisdictions, it's much lower dose. And so we did find kind of around 12. But anyway, so this is called a bubble plot. And so it's just a summary of the various studies that were included. And in this analysis, we did control for like study quality, the country of the study, the publication year, patient diagnosis, et cetera. So this is adjusted. But anything kind of across here means there's no effect. The outcome I'm showing here is all-cause mortality. But what you can see is with low, like less than 12 sessions, we don't really have an impact on all-cause mortality. There is impact on other outcomes, but not on this one. And again, it obviously depends on the length of follow-up as well. And here, when you see with the medium dose, we do have a significant effect, and the coefficient being 0.8, so about 20% less all-cause mortality. But with this high, we get even more, so about 23% less all-cause mortality. So really, the more is better. And we did some other work with our colleagues, Francisco Lopez Jimenez, at Mayo, and we really were able to show there's no ceiling effect. So the more dose, the better. The more sessions that patients receive, the better their outcomes. But again, we have to temper that with feasibility and cost. And then so I kind of thought, like, when we're thinking about dose, well, what are the guidelines and what do they say? Considering, the evidence is a bit, if there's no kind of, we haven't been able to say this is too low, this is too high. And so what do the guidelines say? And so here's a review of cardiac rehab guidelines around the world in various jurisdictions, and the suggestions that they have around exercise sessions per program. And so this is the number of weeks of the program that they recommend and the frequency of exercise sessions per week across these guidelines. And you can see there is really quite a bit of variation, with on average about 9 weeks recommended and exercise 3 times a week. So if we multiply those and get kind of the dose per program, the average was about 28 sessions, but it ranged from, 7.5 all the way up to 48 in quite a few jurisdictions. So you can see, even though, because obviously, I guess we do need to build more evidence because there's such variation in these guidelines on what they're recommending. So we did the global cardiac rehab audit through ICCPR a few years ago now. And this is showing you data about the dose that's offered around the world. And I'm going to show you on this slide the data by region, and then on the next slide by income classification of countries. And so, you can place yourself. So we've got Africa, Americas, Eastern Mediterranean, Europe, Southeast Asia, Western Pacific, and then this is the global value on average. So you can, think about your region, but also just, think here and note the great variation that there is. And you can see, there's a lot of symbols showing that there is much variation. So what we have down here is kind of the number of sessions per week times number of weeks. So this is the number of sessions per program. So on average globally, it's about 22. But you can see in the Americas here, where we have this 36 session norm in the United States that's paid by insurance, it really drives up, higher averages compared to, for example, Southeast Asia and the Western Pacific, where it's really, really quite low at, just over 10. But as you can see, there's, quite a bit of variation even within each region and around the world. So we saw median sessions of 3 and a median number of weeks of 8 around the world. And you can, I guess, think about that in relation to what you have to offer. But also the question of, is it enough to get benefit? And again, there's a difference between what we prescribe to patients and then what they can actually come to, right? And what they adhere to and what barriers they might have. And I hope we can kind of grapple with all those factors. So then, as I mentioned, I wanted to share also the dose data from the global audit by World Bank country income classification. These are low income countries and lower middle income countries. And you can see that, so this is a percentage of sessions, and we just use these thresholds. So, more than 12, at least, if we kind of say it's a floor, and more than 36, which would be very, very high, obviously. So if we even look at this, more than 12 in low and middle income countries, there's very few programs that even can get to 12. In upper middle income countries, we have lower and upper middle and high in our registry. Almost 30% get to the 12 sessions or more, but also almost 20, about 15% are above 36. And then in the high income, over half have at least 12 sessions, with almost 20% over 36% of sessions per program. So with that, I wanted to talk about what's in our registry, but can I just stop there and ask if there are any questions or comments? And if you want to put them in the chat or raise your hand or come off mute. Maybe it doesn't come as much of a surprise to us, right? Because we're living in this every day. Okay. So with that, let me come to the ICRR and what our data shows. So thanks to Fabia, she collated for each of you your, oh yeah, the 0.5 MET improvement. Oh, that's a good point, Anjali. So we had a question from Anjali from our program in India about the MET value after sessions, right? So we do try to recommend a minimum MET increase of 0.5 from pre to post program. And there obviously is some measurement error in measuring METs, and sometimes it can be as much as half a MET. And we do know too, pre-program, sometimes our patients can't get to a maximum and we can't really get a good test, but there is evidence that even a 0.5 MET increase is associated with less mortality. But that is the question is, you know, how many sessions would it take to get that half MET increase? And Anjali, in your experience with patients, I wonder too if it even probably differs, you know, widely based on the patient, you know, how long it would take to get to that increase. Because you're right, I think it's maybe not the sessions per se that are driving the benefit, but maybe the impact on cardiorespiratory fitness. It's a really valid point. And, you know, say a patient that comes in with a really low MET and functional capacity to start, like a heart failure patient, you know, they might benefit quite a bit. And it doesn't maybe look like a lot, but I bet you the impact on their long-term outcomes might be quite substantive, even with low session adherence and just, you know, minor benefit if they're starting out from a low level. And Maria had a great question from India too about whether the sessions home or center based. And exactly, that's, you know, just led into my next point where I've been talking about center based. And, you know, I think when we think about dose, the point is it's difficult to capture secondary prevention. And, you know, do we think these sessions, supervised sessions, are really, if we count them, is that really counting secondary prevention? So, you know, at our center, we've changed to a model where we have one session a week, and we promote patients to do exercise at home most other days, and we have them do recordings and bring in a log. And I'm sure, you know, many other centers use that model as well with an exercise diary. But, you know, it's hard, I think, to measure and I think it's easier now since COVID, right? We can measure unsupervised sessions by, you know, seeing if they come on the phone, or now there's these live sessions, right? And people are there in real time and where you can live stream. And so you can really count that as a session. You see that they're actually exercising the whole time. But measuring these unsupervised sessions can be, it's a bit like measuring apples and oranges. So I think we just have to be careful when we think about it. But I think that the patients that are engaging in exercise unsupervised and between sessions, that really should count as dose, you know, and if they are taking their meds and, you know, eating well every day, you know, that is adherence too. And I think that's going to drive their outcome improvements. So it is difficult to capture it. So there is a limitation in our registry in that we're only capturing supervised sessions and the number, and then we're capturing if they did any online, but we don't have the number online. So that is a limitation. And then we had some other comments in the chat. And then, oh yeah, so do we have data on whether we're dealing with low or high risk patients? So unfortunately, we don't have a risk stratification variable in the registry, but we do have, you know, if the patients have heart failure, what age they are, what comorbidities they have. So, you know, it might have been informative. I should have done that, Farzana, was maybe check the dose by some of those characteristics, because I bet there would be some variation there that would be important to talk about. So I could look that up after. I just made a note of that. Thank you. And then Banish had a comment as well, is typically depends on each individual patient's performance and their health status, you believe, right? Exactly. That's, I think, exactly what I was trying to. So I'm glad that we're on the same page, Banish, about that. we do, right? And I think that's the wonderful kind of element of rehab, is that you develop such individualized relationships with the patients, and you can personalize the care to their status. So here we are looking at averages, which really do kind of gloss over a lot of those important factors, but it gives us a starting point for discussion. Yeah, those are great comments. Anybody else have any questions or comments? Okay, so in the, so Fabia, thank you very much again. So she tallied for everybody the number of sessions that patients attended. So it was supervised only. So the average at your program, and we sent that to you, a few months ago when we were getting this planned. And then she sent it just last week as a reminder, because I'm sure people wouldn't even find it in their inbox after a few months. But so hopefully you can pull that up. And if you can't find it, or if you didn't get it, just, email our Gmail. And if Abby, if you want to put the Gmail in the chat for everybody, then you can email and we'll send that to you again if you didn't get it. And then Farzana made another comment too about struggling with adherence due to factors like home-based as one of solutions, but for home-based, patient safety for high and moderate risk is a big question. And can we help on that? Yeah, that's a great point too. So Dion, can you maybe park that and we can talk about that in the Q&A? Because I think that's a really excellent point, and we're going to raise it. And maybe Claudia too. That's something I'm not sure if you have home-based or if that's something you know about, but maybe you can share about that too. And I have a couple ideas as well, but I think it's challenging. So I think it'd be great to have a dialogue about that, Farzana, for sure, because I agree with you. That is a major solution where it's reimbursed, the home-based. Yeah. Okay, so in the ICRR, patients are participating in an average of 11.76, which is almost 12. So that's kind of like right at that threshold where we're kind of seeing it's the most common around the world, and it's the kind of the threshold where we start to see benefit. So I do think we're, getting to the minimum dose as much as we possibly can. Again, realizing that in low resource settings, the barriers are much higher than they are in higher resource settings. And then program completers. So, patients, obviously, there's what we prescribe in the programs and, how many sessions we can actually feasibly give patients. But then I guess, again, as I said, how many they can actually come to. Do they have coverage? What barriers do they have? And Gabriella will speak to that. But the program completers, I need to stop because I'm going over. The program completers did about 15 sessions, and the non-completers that dropped out did about 7, right? And so sometimes they drop out for return to work or for valid clinical reasons, et cetera. But I'm going to just launch a poll now, and folks can rate. Oopsie, I already, hold on. There we go. So I've got a poll here, and what do you think is the feasible but optimal number of sessions to aim for at your program? Oh, it looks interesting. People are voting. I didn't really give a range, so it might be hard to vote, but okay, I'm going to show the results. Okay, so as you can see, about 36% said 20 and 27% said 36. And then after that, most frequently was depends on the patient. So it is nice if we can be individually tailored, if the program can do that. But I do think that this sounds very much in line with what we're seeing in the data. But it comes to the issue of feasibility that Gabriella will speak to us about. So just to give kudos to the centers that had above that median of 20. So thanks for everybody. Most of you answered 20. So the centers with more than 20 sessions per patient on average or median was in Taiwan, in Colombia. So Dr. Claudia, who it will be speaking, and we have Patricia also from her center on the call. Dr. Carlos Alberto Studart Gomez from Brazil, University Hospital Borno in Czech, and then also the Hamad Medical Corporation in Qatar. And we do have Christina and Lily from that center on the call as well. So if I've missed anybody, please clap for yourselves and put your hands up and in the chat and maybe react, because just, you know, it is difficult. As you can see, there's many places in the world that don't even have 12. So just we commend you for all your hard work. Okay, so with that, I'm going to pass to Gabriella. And so Dr. Giese is an affiliate scientist with Kite at the University Health Networks, where I have the real pleasure of working with her from the University of Toronto, and she focuses on patient education and chronic disease and global access to rehab. She's led the successful development and implementation evaluation of the patient education curriculum Cardiac College in over 10 countries. She's published over 120 papers, clinical guidelines, and cardiac rehab scales. Gabriella is incoming chair of the ICCPR, and she is chair of the ICRR, the Registry User Subcommittee. So over to you, Gabriella.
Hi, Sherry. Hello, everyone. So I guess.
Share your screen.
Yes, I think it's working now. Perfect. It's nice to see everyone. I see some faces because for those that did not know me, I'm the one that do the onboarding. So I met you in the beginning when you're starting the registry. I'm very excited with your progress. So thank you so much. So today I'm going to be talking about, as Sherry said, the barriers, cardiac rehab barriers around the globe, specifically some results of our first ICCPR's first global assessment. We have done this assessment in the past years. We have data from more than 2,000 patients from 16 countries. So I'm going to be sharing with you the top cardiac rehab barriers by world region, as well as comparing some barriers in those that were not yet enrolled in cardiac rehab versus the ones that enrolled. So barriers for them to attend more sessions, participate, discuss some of the mitigation strategies for the top barriers, which were very similar. You're going to see the top barriers in the regions, they're very similar. And I'm sure you're going to identify many of those barriers that are similar to your patients as well. And then how you can assess your patients' barriers. I'm just going to give you some tip on how you can guide your patients if they speak some specific languages. So before I start, how we are assessing those barriers, there is a scale, a validated scale called Cardiac Rehab Barriers Scale, or CRBS, that assess cardiac rehab barriers in multiple levels, so patient, provider, and system level barriers. So patients complete that survey. There is 21 items, and each one of the items has a 5-point Likert type scale. So in each one of the barriers listed, patients have to give a grade that goes from 1, disagree, to 5, strongly agree. And all those 21 items are divided into 4 subscales, which I'm going to show in the next slide. The CRBS is available in 19 languages. There's approximately 45 studies using this scale in 25 countries. So these are the 4 subscales. So there's also the barriers. They are classified into these 4 groups or categories. Number 1, perceived need, healthcare factors. And then I bring you some examples. There's 21 items. Here I just bring some 8 examples. So for this first one, perceived need, I didn't know about cardiac rehab. It's one of the items. I don't need cardiac rehab. In regards to logistical factors, there is one item about distance, cost, transportation issues, family responsibilities. Then there is a subscale on work, time conflicts items or barriers. So some examples of those items are travel time constraints, work responsibilities. And then the final subscale, it's comorbidities and functional status. So I find exercise tiring or painful, and I am too old. So let me bring you the top cardiac rehab barriers by world region, starting with the African region. So you're going to see the next 6 slides or 5 slides, not counting this one. I have the map. I'm highlighting the regions, so you kind of know. If you don't know which World Heart Organization region your country is, you can see in the map. And I bring below the map, highlighting the top scales that have the highest barriers. So in this case, African region, we have logistical factors and perceived need in healthcare as the areas with the highest barriers. And then I'm going to really focus my talk in the interest of time in the bullet points. So it's really in the items. And then you're going to see between parentheses, there is this, there's 2 numbers, right? 5 is the maximum score for each item, and then the mean. And what happens with the CRBS is that the highest, closer to 5, indicates higher barriers. Okay, so patients, so higher numbers, higher barriers. Okay, so in African region, the top cardiac rehab barriers that those patients identified were other health problems prevent me from going to cardiac rehab, cost, I didn't know about cardiac rehab, and many people with heart problems don't go to cardiac rehab and they are fine. In the Americas, the 2 out of the 4 subscale areas with the highest barriers were logistical factors and work time conflicts, and the items, again, the bullet points, were other health problems prevent me from going, travel, work responsibilities, family responsibilities, and cost. In Europe, top cardiac rehab barriers were other health problems prevent me from going. My doctor didn't feel it was necessary. Distance, I already exercise at home or in my community, and I didn't know about cardiac rehab. In the Eastern Mediterranean region, top cardiac rehab barriers that we identify are the following. I didn't know about cardiac rehab, distance, transportation problems, cost. My doctor didn't feel it was necessary. In the Southeast Asia region, these are the top barriers by items. And remember to look in the square. I don't want to, because I have lots of slides. So I just want, in the interest of time, I want to go just focus on the points. I didn't know about cardiac rehab, severe weather, distance, work responsibilities, time constraints. As you can see that I'm talking about the top cardiac rehab barriers, they're very similar between regions. So not knowing about cardiac rehab, it's a major barrier to identify multiple regions, work responsibilities, family responsibilities as well. So let's go to the Western Pacific. Again, I didn't know about cardiac rehab. I prefer to take care of my health alone. I think I was referred, but the rehab program didn't contact me. Cost, I already exercise at home and in my community. Okay, so before I go to talk a little bit about the top cardiac rehab barriers by cardiac rehab enrollment, I don't have a slide here, but I just want to highlight that for low and middle income countries, the top areas for barriers are the logistical factors and also perceived need, healthcare factors. So I didn't know about cardiac rehab. It's a major thing about it's one of the top barriers for low and middle income countries. And also my doctor didn't endorse cardiac rehab, didn't refer me as well. Okay, so not enrolled versus enrolled. Not yet enrolled, these are the top barriers that the patients identified. I didn't know about cardiac rehab, cost. I prefer to take care of my health alone, and I think I was referred, but the rehab program didn't contact me. Versus the ones that are already enrolled in cardiac rehab, the barriers that they identify related to attending more sessions and being part of the program. It's other health problems, work responsibilities, family responsibilities, and distance to the program. So let's talk about some mitigation strategies for the top barriers that the survey identified, the study identified. So the main one was, I didn't know about cardiac rehab. So these are some mitigation strategies. We can refer patients to resources and websites where they can find more information about cardiac rehab. We can reinforce the many benefits of cardiac rehab participation, suggest they contact their primary care provider about getting a referral, maybe a cardiac specialist, and ask them to complete the cardiac, the CRBS, the survey online, and share the results with the healthcare providers so they can understand, wow, patients have barriers. And I'm going to talk about that in my last slide. If the barrier is distance, we can work to check with the patient if there is a cardiac rehab program that it's closer to their home or their work. And if not, patients can also ask if there is a home-based cardiac option that they can enroll. If they don't have a contact at the cardiac rehab program, they can ask their primary care provider to find out if there is a closer program. If there is no program closed and the program cannot support home program, they have some options. They can have an appointment with the physiotherapist and maybe develop an exercise plan. They can work with their primary care provider to make sure that all hard risk factors are controlled. And also there is an option of this 12-week program, education program called Thrive, which is really based on setting heart healthy goals each week to ultimately have a better health. If the barrier is cost, here are some suggestions for mitigation strategies. Encourage patients to ask the cardiac rehab team about the cost to attend the program and any free options available. Patients can also talk to their providers about any available program with no cost, maybe community centers. Alternatively, if patients cannot afford cardiac rehab and there is no low option cost, they can have an appointment with the physiotherapist. Again, they can work with the healthcare team to make sure that the risk factors are controlled, and they can go online. And again, here's the Thrive 12-week program. If the concerns are related to cost for transportation, also they have to connect with the cardiac rehab team and see if there is any lower costs for parking, public transportations, and so on. If they already, if the barrier is already exercised at home or in my community, congratulate the patient. It's great that they are active, of course. Reinforce the cardiac rehab. It's not only about exercise. Many patients think that. So really, it's about all the other aspects, eating healthy, psychosocial support, and so on. And reinforce the benefits of participating in cardiac rehab. Another very common barrier that people identified was many people with heart problems don't go to cardiac rehab and they are fine. And one of the strategies that we suggest is reinforce the message that cardiac rehab is recommended to all heart patients. And those that participate will likely live many more years than the patients that do not. My doctor didn't feel it was necessary. It's unfortunate. Maybe address that. Tell patients they can get referral to cardiac rehab by any physician, and reinforce the importance of cardiac rehab to their health and the need to get the referral soon. Other health problems prevent me from going. That's also a major thing. And one of the key, it was the top barrier for those that attend cardiac rehab. So reinforce the message, these are the strategies, reinforce the message that almost every cardiac rehab participant has a health problem other than heart disease. And then cardiac rehab, it's there to support them in their overall health. Provide some examples. For patients with diabetes, the rehab team can teach them about the health eating, assist them with the blood sugar, teach them about carrying with their feet. For those with arthritis, the rehab team can suggest non-weight bearing exercise and work with them to achieve pain control. For those with osteoporosis, they can assist when supporting with the risk of fall and put extra safety measures in place. And remind also that exercise is beneficial in so many conditions. So my final slide is how you can assess your patient's barriers. Maybe it would be great for you to work with them and assist them to understand and overcome those barriers. In the ICCPR website, globalcardiacrehab.com, if you go to cardiac resources, then you click for patients and assessment of cardiac barriers. We have CRBS, the survey or the questionnaire, set up online. So patients can complete online in those 5 languages here: English, Spanish, Portuguese, simplified Chinese, and Arabic. They have to consent. They can complete the online survey and get mitigation strategies automatically. So it's a system that will generate those strategies based on the top barriers they identified. They can save those strategies, they can print, and they are encouraged to share with the cardiac rehab team and healthcare providers to start that important discussion. So you can scan this QR code, or you can go to the website and follow that path that I put in the second point. Thank you.
Thank you so much. Okay, so that was excellent. Thank you so much. And I just put in the chat, kind of the resources that you were mentioning as you went along. So I hope everybody was able to follow along and just see those resources there. But please don't hesitate to email, because we're very happy to provide these afterwards if you missed them or whatnot. But we're also recording it too, and we can share that. So I just wanted to, before I pass to our site, high performing site, just to reiterate that these mitigation strategies, so in the cardiac rehab barrier scale, we measure 21 strategies and barriers, and there's an option for like other barriers too. So patients can list other ones that they have and share them with you. And the responses or the strategies that Gabriella just shared with you, we do have them posted on the web, and you can see the link here, and I just put it for you in the chat. It's right here on this page. So application, kind of talking about what to do, and then the file here in English, but we do have the barriers strategies, the mitigation strategies, translated to several languages too. So if you're interested, we can share those with you. But patients do find them quite helpful. And also we are doing a trial to assess whether giving these strategies to the patients and talking to them about their barriers actually results in greater use. So that remains to be determined. We hope so. Yeah, here's a reference about the development of these mitigation strategies and testing of them, and then the link for you. So let me now pass to Dr. Claudia Enrique Santos. She is a physician, a cardiologist at Med Diagnostica Colombia. She is the director of cardiology there and also the director of cardiac rehabilitation. She's an associate editor with the journal Revista Colombiana de Cardiology. She's heavily involved in the Colombian Cardiology Society and the subgroups related to cardiac rehab and women. I've had the pleasure of meeting her at a conference over 10 years ago now, or 10 years, actually 10 years exactly. And she has been a site in the ICRR since the spring of 2022, so about 1.5 years. And as we've heard, she's demonstrated high quality in our program through her participation. So let me pass it to you, Dr. Enrique Santos.
So thank you very much. I'm going to share my screen. Is that okay?
Yes, please.
Okay. So you hear me okay, yes?
Yes.
Okay. So good morning to you all. Thanks, Sherry. Thanks, Gabriela. Over the next 8 minutes, I'm going to share some of the practices we have implemented in order to increase patients' adherence into our cardiac rehab program, which is located in Duitama, Colombia, South America. Our program is situated.
I don't, just one second, Claudia, I don't see your screen. Does everyone else see your screen?
Yes, it's visible.
You can? It's me then. Okay, sorry, please go ahead.
Okay. So our program is located in an urban area outside the facilities of a hospital or medical center, and we offer phase 2, 3, and 4. When we were asked to talk in this webinar, we decided to ask for our patient opinions. So we conducted a survey with 30 questions that included different aspects related to patient cardiac rehab adherence. 161 patients responded to the questionnaire. 26 issues were considered extremely important, 4 were considered important, and none of the issues were considered indifferent or not important. So we grouped them and chose 9 to share with you today. This is a summary of the 9 practices we are going to talk about. So let's begin with number 1. Number 1 is related to the reference. The authorization to attend cardiac rehab is covered for all patients by the National Health System. And we have been working for the last 25 years with physicians of different specialties applying strategies to increase the number of people being referred to cardiac rehab. The number 2, our number 2 practice is the opportunity to take place in cardiac rehabilitation. The amount of time between the patient being authorized to participate in cardiac rehab and the assigning of an appointment for the beginning of the program is usually no more than 4 days compared to the national average of 4 weeks. Number 3 is the variety of choices in hours and sessions. We are able to offer flexibility for patients in times and days from Monday to Friday, according to their wishes and depending on their personal circumstances. For example, people that work in morning or the afternoon, or maybe students or having an exam in another place, etc. So they can schedule weekly their sessions. Now we can pass to number 4. Depending on each patient, we can offer 3 different models of cardiac rehab. We have the supervised in-person model, as you can see here, the supervised virtual, and the hybrid model. So this helps to the different patients, and they can change from one to other when they want. So now we can pass to number 5. Number 5 is related with the sessions authorized. The first authorization for cardiac rehabilitation varies in the number of sessions depending on the doctor who authorizes them or depending on a particular administrative decision from individual insurance companies. So in most cases, if a patient needs more sessions in order to complete the number of recommended sessions in the program, we are able to request the authorization from insurance companies. And this means it is easier for patients to continue with their program. Now, number 6 is the comprehensive assessment. All our team worked very hard in this comprehensive assessment. This includes 7 tests for stratification, assessment for risk factors, tests to define physical and mental status, and assessment of diagnosis, treatment, and potential challenges for the patients. Now we can go to the number 7, the safety barriers. Keeping patients safe with different strategies applied during the exercise sessions is crucial for patients and for us. So I will show you 3 of these strategies. The first one is what we call the budget, the personal name budgets containing basic information for easy identification for each patient, such as the name, the patient diagnosis, risk stratification, and exercise limitations. You can see this is the model of the budget, and these are some examples of the budget. So in a very quickly way, you can see, you can have a lot of information. For example, Jose Carmen Ochoa, you know, he is in the number 36 sessions, PCI, he has heart failure, pacemaker, he is high-risk ACVPR, high-risk falls, he can practice resistant exercises, and he has no sarcopenia. In the bottom of the slide, you can see Jorge Ivan with 18 sessions, PCI, diabetes, high-risk ACVPR, thirds of angina during the exercise, and he can do resistant exercise of lower limbs, and he has no sarcopenia. So these are some examples so you can understand the importance of this practice for us and for our patients. The second one is the ECG monitoring when necessary or according to the protocol. And the third one of the safety barriers are following specific protocols for hypoglycemia, hyperglycemia, hypertension, hypotension, arrhythmias, heart failure if it is necessary. Now we can move to the session characteristics as the other practice, this other group. Keeping patients updated on all aspects of the program and reassuring them by always being available and accessible to them if they have any problems or worries is very important. So these are the 4 practices of this group. The first one is the presence of physicians, nurses, and physiotherapists at every single session. The second one is the feedback, treatment, and resolution of patients' doubts during the session. We show the patients their outcomes in an easy way, as you can see here. We show them slides of the functional capacity, quality of lives, how they are in lipids, the daily the daily steps, so they can know and feel how they are improving each kind of the outcomes. The third one is the variety of exercises during the sessions that changes every 14 days. And these are some slides that give you an idea of the different kind of exercises I am telling you. The last one of this group is the communication. This is a very important practice for us. The phone call to patients that couldn't attend to the assigned session, inquiring as to what the reasons were for the non-attendance and what can be done to minimize the number of missed sessions. And we repeat this call the number of times it is needed. This is very important for us. Now we can pass to the last group of our practices, the promoting relationships between the patients themselves and with the staffs. Here we have 3 practices. The first one, the educational sessions and the educational activities that represent an opportunity for both for patients and staff to share their experiences and worries in relation to the program and learn more about their treatment and healthy lifestyles. These are some examples of the different activities. These activities and these educational activities, we have them in presential, of course, but we also give them in a virtual way. So we pretend to give an access for the patients virtual and presential. The second practice of this group are the leisure activities for patients and families. They are also very important. For example, we encouraging patients to bring healthy alternatives to traditional Christmas or Halloween food and sharing with each other or this kind of food. Or maybe encouraging them also to do exercises with their families and with their friends, also participating in different contests and challenges, always related with healthy lifestyles. So they feel very happy. We give some souvenirs, some little presents. We motivate them every time they participate. So we feel this is very important for them. And this is also medicine. So it's the way we traduce medicine for them. And these are the different activities. With other cardiac rehabilitation programs, we invite other cardiac rehabilitation programs to do the same, to share these activities. And also these activities are done in presential, but also for virtual patients. As you can see here, Christmas, for example. And the last practice of this group of practices are related to communication using technology. We have a chat group where patients can share experiences between themselves, and also we can send reminders of healthy lifestyles options, invitations to different activities, and useful health information to keep them very motivated. So these are some examples of what they write to us, sharing what they do with their families or the days they don't come to our program. Here are some examples of what we ask them to respond to us, to our practices, for example, and also we send other information. So this is again the summary of the 9 practices. While we appreciate there are cultural differences around the world, and maybe some of these practices are not appropriate in all the countries, we believe or think that the majority of them can be adapted to suit the need of your patients. So this is a picture of some of our patients, and the ones that have the green heart, they are part of our staff. And this is the last picture in the name of our patients and my staff to say thank you, Sherry, thank you, Gabriela, for inviting us to share these minutes, to share these practices that we do every day with our patients. So thank you very much.
That was excellent. Thank you so much. It was really, really helpful. Okay, so let me share my screen again. Okay, so I'm conscious that we are running out of time too. And the wonderful part is that we have scheduled November 22nd, because we need to hear from you at that time. And we'll have more time to chat, in particular to ask and discuss the question about safety in the home exercise. But I'm just going to quickly conclude and pass to Dion, who's just going to give you some last wrap-up points. So my concluding points are that the goal is not just to get patients to come to the sessions, but to adhere to all of the heart health recommendations for secondary prevention. There are some trials on how to increase adherence, and I've just put the Cochrane review on that in the chat. And we're actually updating that right now. So that will be exciting to see if there's anything new. But things like, motivational interviewing, automated reminders are helpful. Financial incentives work, but I don't think they're very feasible in practice. And then many of the barriers are structural, and so we can't overcome them by the patient. And some of them are even hard for you as a program to overcome based on institutional barriers. So we have to recognize that and work within those constraints. So with that, let me pass to our ICRR user subcommittee lead for quality, Dr. Dion Candelaria, who's an earlier career researcher from the University of Sydney Faculty of Medicine and Health School of Nursing and Midwifery in Australia. He's a cardiac registered nurse specialist, and his research focuses on supporting patients to reduce the risk of events. And he completed his PhD in 2013 on cardiac rehab service delivery characteristics. And he's currently doing a postdoc, a federally funded postdoc, and he works with our chair of ICCPR, Dr. Robin Gallagher. And please, over to you, Dion, and I can progress the slides for you.
Yeah, thank you. Thank you very much, Sherry. And fantastic talks and amazing tips, Claudia. I think a lot of the participants here today would learn a lot from someone like you who's doing amazing things. And with that, I'd like to plug in that we're conducting QI community sessions, and this is where we really foster collaboration and sharing of advice and sharing of what works for your service, because it might be applicable for other services. It's open to all interested interested ICRR stewards like yourself. It is not recorded. It is a safe space. You can bounce off ideas with each other. It's definitely non-judgmental, and it's really opening up for discussion of implementation experiences and challenges. So the next one is going to be on the 22nd of November, 8:30 a.m. EDT, and it's for an hour. So do let us know, email iccpr.icrr@gmail.com if you haven't received the calendar invite. And also, we, as a reminder, there are video training resources in our website. 3 of them: Introduction to Registry, and Pre-Program Assessment Data Entry, Program Assessment Data Entry, and Registry Features. Also, there's a YouTube video on what is quality improvement, and how does that apply to cardiac rehabilitation. So I think so that was definitely a valuable resource for you. And with that, I am 1 minute over. Thank you very much, everyone, and thank you, Sherry, for sharing, and thank you, Gabriela and Claudia, as well.
Yes, thank you, and kudos to everybody for all your hard work. We look forward to hearing from you on November 22nd. We'll share the recording with you. Please send us any questions or comments in the interim. And yeah, happy providing care to everybody. Thank you so much.
Thank you.
Bye-bye.